I guess I'll get started. So this is a presentation on how to acutely manage traumatic dental injuries in kids coming to the ED for dental complaints. And then this was adapted from Dr. Shadmere. She's an endodontist at UCSF, and Dr. Twanley. He's a pediatric dentist at UCSF. Okay, so today's objectives are to understand basic tooth anatomy, define types of dental injuries, obtain proper evaluation and diagnostic images, and develop appropriate initial treatment in the emergency department, and know when to refer. So just a little bit of background, about 40% of somatic injuries in kids occur in the oral facial region. About 33% of adults have had pediatric dental trauma in their lifetime, and most occur between the ages of 2 to 3 and in male kids. And then school-age kids, their front teeth are most likely to be affected, and especially kids with their front teeth that like protrude outwards, they're more likely to be affected. And these are all from the American Academy of Pediatric Dentistry. So basic tooth anatomy, there's two main parts, the tooth and the bony structure. The tooth, you have the crown of the tooth, which is the part you see in the mouth, and then the root that's embedded in the bony socket. And the tooth itself has three parts, the enamel, dentin, and pulp. The enamel is the outermost layer. It's translucent in color. The dentin is more yellow, and then the pulp contains the nerve and blood supply. And then the bony structure houses, it has the alveolar socket, which is part of the mandible and maxilla. There's the periodontal ligament, which we abbreviate as the PDL. And they're little ligaments that are attached all along the root surface to the alveolar bone. And it allows for movement of the tooth within the socket, but prevents it from coming out. And then you have the gum tissue, which is a pink structure that surrounds the gums and protects the root a little bit of the tooth. So for pediatric dentition, there are 20 teeth in a pediatric patient's mouth. They usually start to erupt from front to back. So if you're looking at this photo, this is like the upper teeth and the lower teeth. And the way you can divide the teeth is to look at them into 4 quadrants. So if you look at this mouth and put a line down the center and a line across, this would be considered the upper right quadrant. This would be the upper left, the lower left, and the lower right. And so when you're kind of identifying different spots, it's really nice to just say, oh, it's in the upper left quadrant or the upper right. And that way you can kind of be a little bit more specific when you're looking for whatever you're looking for. This is information about when they erupt and when they shed, basically when they fall out. Typically they'll erupt and they'll fall out from front to back. And by the age of 3, you should have all of your primary teeth. On this side, it's the permanent teeth. Again, they will erupt similarly to the primary teeth. They'll erupt front to back. And typically you'll start to get your front teeth around 6 to 7 years old. And then your last teeth will come in around anywhere up to 25 years old. And for the permanent teeth, you have 32 teeth total. So you have more teeth in the permanent dentition than you do in the primary. For kids that are school age, they're in a phase called mixed dentition. Basically, you have both permanent and baby teeth. And primary teeth, when you're looking at them, the baby teeth are usually whiter in color. So as you can see here, these are a little whiter. They're a little smaller. They're more square shaped. They have shorter roots. So if they have trauma, more likely they're going to come out. There's nothing holding that tooth really in. And they have larger pulps. So if they get cracked, you're more likely going to have that pulp exposed, which can require a little bit more dental treatment. This is a picture of a full mouth x-ray. This is just to show a patient in mixed dentition. So you can see these little buds of teeth that are developing behind the baby teeth. And it's really cool because the baby teeth roots will start to shrink away and resorb and as the permanent tooth comes in. And as the permanent tooth comes in, the roots start to develop. So as you can see right here, these roots are not fully developed, but they are starting to come in. And just based on this picture, you could guesstimate that this patient is probably around 7 or 8 years old, just based on the tooth patterns, which is really neat to see. Sometimes it's kind of off topic, but sometimes in like the juvenile system, if there's a person that says they're 16 years old, they will sometimes take radiographs just to see where their third molar development is, these back teeth, to really see if they're truly the age they say they are. This is a good website. It's called dentaltraumaguide.org, and it shows you what kinds of definitions of trauma there can be for a tooth, and also how to manage them. But basically, they're divided into 2 categories: fractures and luxations. Fractures have to do with the actual tooth, and luxations have to do with the position of that tooth during an accident. So crown fractures, we're going to look over here, and they can be uncomplicated or complicated. And each of these categories can fall into either crown, just affecting the crown of the tooth, the crown root, or just the root. So for uncomplicated fractures, these involve just the first layer or the first 2 layers of the tooth. So this is an example of just chipping the enamel, that outer layer. And then this is an example of chipping both the enamel and dentin layer. This basically, uncomplicated means that there's no pulp exposure. With complicated, it involves all 3 layers. So as you can see in this picture, you can clearly see the enamel, dentin, and pulp. The pulp contains that nerve and blood supply, so you're going to see bleeding from the center of the tooth. And a lot of times, as you go farther down onto the crown, like more towards the root of the tooth, you're more likely going to have a pulp exposure. And this is not ideal because then the nerve and the blood supply can eventually be lost, but it depends on a couple of different factors. Crown root fractures basically just mean that the fracture has penetrated all the way onto the root surface, and that can affect the long-term prognosis of the tooth. So luxations look into position within the arch. So there are different classifications of those, and we'll go over those right now. Here are the different types of luxations, and they can affect both primary teeth, and you have a permanent tooth that's right behind, or it could just affect the permanent teeth. And they can be classified into minor, major injuries. Usually if there's an alveolar fracture, so if there's a fracture of the maxillary or mandibular bone that houses the teeth, it will be considered a major one and require a little more treatment. Avulsions is something that we're going to focus on a little later because these will require initial treatment by the ED, and we can do a better job of expediting treatment for these patients when they come in. So just more definitions. A concussion basically means that there's tenderness to the tooth when you tap it or push it, but there's no clinical abnormalities. It looks just the same as it would regularly within the mouth. Subluxation is a little bit more impact. So the tissue around it may have a little bit of bleeding, but the tooth is still maintained within the regular arch form. Luxation injuries, most of these occur with a patient that like comes in for like a ground level fall maybe, or as extensive as like bike injury, going over the handlebars or falling from the bed or hitting the couch or something. These are the types of injuries that you'll most likely see with those. Extrusive luxation basically means that the tooth comes out of the socket a little bit. So those ligaments that are attached to the tooth get stretched. And you can see radiographically how it's not fully in the socket. And clinically, what you'll see is that the tooth is lower than the other teeth. So it's not aligned. With a patient who is starting to lose their teeth and their teeth are coming in, their teeth might look unaligned at baseline. So it's a good idea to get the parents to assess whether or not that this is their normal, or if it looks different than before the injury. And usually this will be associated with bleeding, pain, some swelling or soft tissue injuries as well. Lateral luxations means that the tooth root goes either forward or back or side to side. Most of the time with an injury with a fall, a patient will knock their front tooth and the root will go forward. The forward impact can break this bony structure. So if you're looking at, I have a little type on QDC, but if you're looking at the teeth in the arch, the bone right here, it's called the buccal bone, is really, really thin. And so a lot of times that can fracture. And when you palpate around the tooth, you'll be able to feel like a hard, bony stop right there. Usually with that, if there is an alveolar fracture, the tooth won't be mobile. You won't really be able to move it too much. And then intrusive, this type of injury usually occurs when a patient is like jumping up and down and then falls and hits their chin, and maybe their teeth, their jaw will hit the top teeth and push it all the way into their alveolus. And so usually it will look shorter than normal, and sometimes it can be associated with either a root fracture, so an actual fracture of the tooth, or an alveolar fracture, so fracture of the maxillary bone. And then avulsion, this is complete separation of the tooth from the alveolus. This, a lot of times the patients will come in with the tooth in their hand and say like, my tooth fell out. Sometimes if they can't find the tooth, it's important for us to rule out if the injury is an intrusion. Sometimes the tooth can be dislodged all the way into the socket that you can't even see it. And so if you can't find the tooth, you have to make sure that it's truly avulsed, or if it's just intruded into the socket. So for the exam, it's important to get a good chief complaint, HPI, past medical history, the primary assessment, obviously ruling out any medical need for like a closed head injury protocol. The focused dental exam then comes after that once they're medically stable. So for the focused history, I think this is more geared towards MDs, but as nurses, we can kind of help encourage getting a good history. Just because a lot of times when dentists are called, they ask for pictures. We want to know the mechanism. When did it occur? How did it occur? Where did it occur? And these will give us them a better idea of how to treat and if they need to come in. Again, with this comes with pictures. A lot of times the dentist will want a photo of the actual injury. And then the past medical history, just some specifics like bleeding disorders, since the mouth is very vascular. If they have like hemophilia, it's important that we give them medication if we have to manipulate that tissue. Some cardiac diseases like congenital issues may require pre-medication antibiotics before manipulating the dentition to prevent some endocarditis and things like that. And then tetanus status, if the injury occurred in a dirty area, if the tooth fell in like dirty soil, we may need to give a tetanus booster. And usually that's recommended within 48 hours. So if they're in the ED and have an injury, that's something that we could do there. And then intraoral, extraoral exam. We want to inspect for any abnormalities in symmetry. So in their smile line, if they have any facial swelling, any soft tissue injuries. We want to palpate the facial skeleton and look at the range of motion of the mandible, and then assessing the cranial nerves. This patient, it looks like this side is swollen a little bit. Do you guys agree? Like it looks a little larger, just slightly, right? I'm gonna assume yes. But this actually is a patient undergoing orthodontic treatment because her mandible is growing larger on the left side than the right side. And if you can look at her smile line, like right here, this edge is coming up a little higher than this edge. So it's really important also to ask the parents if this is their normal, because you may assume that this is like swelling or something, but it could just be their baseline. Their mandibles tend to grow until their late teens. So they're still growing in this area. And it's important to know whether that's an acute injury related or if it's just something that is their baseline. Intraoral exam, good to inspect their teeth to make sure that nothing is missing or if anything is misplaced. One big sign is to ask them if they bite down, if their teeth feel normal when they bite. A lot of times, if it's abnormal, that means that their teeth are just not aligned correctly, or their mandible or their maxilla could be fractured in an area. And then obviously assessing soft tissue, making sure that there's no significant bleeding or dislodgement of foreign bodies, and then palpating the areas to make sure that none of the teeth are loose and risk for aspiration and things like that. For diagnostic imaging, this is more for the doctors, but a lot of times, again, they want good photos, and good photos, they like to have the full face to see if anything outside the mouth is abnormal. So if there's like significant swelling and things like that. For the teeth, they like to have a view of the actual injury. Two views that are good are the full-on frontal view and then an occlusal view. That way you can kind of see from two angles what the teeth look like. And then just sometimes they'll order x-rays. And I think as like nurses, we could just do a good job of advocating on the patient's behalf, using the LARA principle in mind. This means as low as reasonably achievable. So basically you want to minimize the amount of radiation exposure with maximizing what you're trying to look for. So here's an example of a patient who came in. He was like 4, was riding on his bike and hit something. Dad couldn't find the tooth. Upon further evaluation, we found like something hard in his lower lip, and there was no concern for any mandibular fracture. We were just looking for this little tooth, and this patient ended up getting a full lateral cephalogram, but 5 images. And that's like a lot of radiation just to rule out if this tooth was actually dislodged in the soft tissue or not. So for this case, that was probably too extensive for what we were looking for, and the patient probably could have gotten just like a little soft tissue image of just the lower lip. There's no need to get this whole thing. So we can advocate for patients when they are trying to rule out something like that. And then this is information about maxillary and mandibular palpation. A lot of times this is missed when a patient has a traumatic facial injury and they think it's just the teeth. And it doesn't even have to be like a significant severe injury. They could have just like been falling, ground level fall, knock their chin, and then they're happy. but a lot of times the mandibular injuries and fractures can be missed. So good questions to ask is, when they open or close their mouth, do they feel pain? And does the jaw deviate when they open or close? And that basically means that when you close or open, does the jaw not align on its regular occlusion? And then when they bite together, does it feel off? So those are indications that it may be something more than just the teeth that are involved. For mandibular fracture, the most common injuries that occur are right at the angle and body of the mandible, so around right here. And then the second most common is the underneath the condyle. So that's when you open and close, that's like the thinnest part of the mandible. This patient had a subcondylar fracture of the mandible. And when you are assessing this patient, when they bite down, their mouth is going to, or their jaw is going to deviate towards the side of the injury. So when they close, their bite will kind of deviate like that. And it may not be very significant, but it will feel weird when you look at them opening and closing. It won't look even. This patient came into the ED for a bilateral subcondylar fracture, and they had a fracture here and a fracture here, and they also had like the small midline fracture. She had fallen down a flight of stairs, and when she was biting, she said that she couldn't close her mouth all the way. So when you looked at her teeth and had her bite down, her teeth were like only biting on the back teeth, and the front teeth were like open. So when she closed her mouth, it looked like that. So it's also good to assess their bite to see. She was complaining of pain when you touched it. She was complaining that her teeth weren't coming together. And she was also complaining of pain when she bit down. So those were all signs that we needed to rule out a mandibular fracture. So management of dental trauma, again, it's good to get a thorough history and present illness. We want to get good imaging and photos. Acute management, definitely want to rule out a more serious head trauma injury and manage any bleeding or soft tissue swelling. Pain management is a big one, and behavioral management is also a big one in kids. Using child life and then preparing them for possible sedation before the dental team gets there will help kind of expedite that treatment. The reason why I say a lot of behavioral management is because with dental treatment, they can't see what's happening. And so and they obviously have to be very still. So just preparing them well before the dentists come in will make that treatment a lot faster for them. The goals is to control bleeding, pain, and infection for all patients, but specifically when you're looking at the baby teeth, we want to protect the developing tooth behind it. And then for permanent teeth, we want to maintain the vitality of that tooth, make sure that root is continuing to develop, and to restore function and aesthetics. General acute management of the primary tooth really depends on the case, but for the most part, it's just to protect the incoming tooth. So there's not a whole lot we would really do. It's mainly just controlling the swelling, behavior management, controlling the pain before the dentist decides what their definitive treatment will be. A lot of times it will involve just taking the tooth out or just leaving it alone. So for permanent teeth, it depends on how severe the trauma was. And it's really case dependent, but here this patient's tooth got realigned, and then they repositioned it, and then they put this wire splint, and then they sutured the soft tissue. For the most part, 3 through 6, if there's any misalignment of the tooth in the arch, most likely the dentist will need to come in and treat it. And then for nursing and MD standpoint, this is probably the most important management that we can start before the dentist arrives. So let's say a patient comes in, they're 9, they have a permanent front tooth, they were playing soccer, got hit really hard and their tooth fell out, and they have it in their hand, and they come to triage and they're like, what do we do? So from nursing, just keep these goals in mind of an avulsion management. We want to maintain the cells, and we want to make sure those cells are alive. So there's 2 basic cell types. One is the root stem cells. So as you can see in this photo and in this one, the root is blunted. It's not very pointy at the end. The pulp right here is very large. These roots are still developing. So that means that there's stem cells that are there to try and continue that root development. Then also on any tooth, you have the ligament cells, those cells that attach the ligament to the root surface. And those ones will help keep the tooth in its socket, in place. So keeping those 2 cell types alive is really important. And the best way to do that is to keep it in its original environment. So that's why we want to reimplant those teeth as soon as possible. The management depends on a couple of things. One of them is extra oral dry time. So how long has the tooth been out of the mouth? If it's less than an hour, the prognosis of the cell survival is better. If it's been more than an hour and it has been dry out of the mouth without any medium or any solution, then the prognosis of that tooth goes way down. And so if a patient comes in, it's important to know when the injury occurred, and if they have the tooth, then we should be able to place that tooth back into its socket. If the tooth is unable to be put back into the socket, the best alternative is to put it in a storage medium. Milk is the best, never water. Milk, even if the patient we'll have access to milk from the ED, but if you don't have milk, you can have the patient spit in a cup and just have the tooth sitting in there. And the reason we like milk is because it has a lot of ions, it has proteins, and it just buys a little bit more time to make that tooth a little happier before the dentist comes in. If we place it in water, it's not isotonic fluid, and so it will pull all of the water out of the cells, and the cells will eventually die. And then it's important to handle the tooth correctly. So you never want to touch the root. The root has all of those cells on it, so touching it can infect them or it can wipe them away. And then knowing the mechanism of injury is important, because we want to implant a clean tooth. We don't want it to be soiled. And then after the acute management, there's basically, dentists will have to decide the definitive acute treatment after we get the full history. And that depends on a variety of factors. It depends on the time, it depends on the maturity of the tooth, it depends on the mechanism of injury. And so this is just to show you that there are the treatment options all vary. But the important thing is, if we have a patient that comes in with a tooth in hand, we want to reimplant that back into the socket or put it in a storage medium and call the on-call dentist right away. So to summarize, a patient comes in, knocks his front tooth out. You only want to touch it by the crown, never the root, because of those stem cells. If it's dirty, we want to rinse it off gently. We can use lukewarm water or normal saline, but never wipe the tooth, never dry the tooth, and place that immediately back into the socket. If for some reason the injury happened like 2 hours ago, there's a lot of swelling, there's blood clot, you can't put the tooth back in, we want to put it in a storage medium, and that is milk or saliva or normal saline, but milk is the best. And then consult the dentist. Even like maybe during the winter months and it's busy and the dental patient is really not urgent, you could still either place that back into the mouth and then or put it in a storage medium, and then have someone page the on-call dentist, because during that time while they wait, the dentist can at least get a good kind of talk to the patient or get information to decide whether or not they need to come in and treat that tooth. Again, the hour marking is kind of a cutoff for the survival of that tooth, and so it's important that we see these patients pretty quickly. For all avulsions, that get reimplanted back into the mouth, we're going to give them systemic antibiotics, either amoxicillin or penicillin. If they are allergic, we can give them tetracycline, but tetracycline can inhibit skeletal calcification. So this is contraindicated in patients that are less than 12 years old because the teeth are developing while they're young. Their teeth can get staining. So we don't recommend tetracycline. If they're allergic to any penicillins, we can give clindamycin. We'll give them a mouth rinse, that's an antimicrobial mouth rinse, and then we want to assess their tetanus status and give a booster while they're in the emergency department. And then this is just information about what happens if there's delayed implantation. Those ligament cells will die, and then there'll be no ligament that is between the tooth and the bone. And what happens with that is it can lead to ankylosis. So the tooth will become permanently locked into place. And why that is a problem, not only from an aesthetic standpoint, the tooth may look shorter, it may not be aligned in the arch correctly, but as a patient grows, their maxilla and their mandible will continue to grow. So it will look misaligned in the arch, and also it can affect their function. So it's their speech, it can affect their ability to bite, and there's really nothing you can do about it. Like braces really won't move that tooth significantly. Also, there's a risk for discoloration. Sometimes if the tooth is traumatized, it will discolor. Sometimes if the permanent developing tooth bud is traumatized, not only can it discolor, but it can not mineralize as well. So when the tooth erupts, it will be more prone to cavities. So for the goal of, if it's reimplanted late, is just to temporarily restore it for function and aesthetics. And then for post-op instructions, if they leave the ED, we want to tell them to avoid participating in any contact sports, soft diet for 2 weeks. They can brush that area using a soft bristled toothbrush. We want to make sure that area is very clean because you don't want it to get infected. They'll have that mouth rinse, the antimicrobial mouth rinse. They'll want to follow up with a dentist within the next few days to a week, and then consider a mouth guard for future play. And those are all recommendations by the American Academy of Pediatric Dentistry. Any questions?
So would there be any reason to replace a primary tooth? I mean, is it like the root is really small, you said, so does it guide the secondary teeth in or?
Yeah, so basically the main function of a primary tooth is a holding space for the permanent tooth. If the primary tooth is missing and you have, and the patient is growing, what's going to happen is that all the other teeth are going to drift into that space, and there won't be enough room for that permanent tooth to come in. So it depends on a couple of things, but one of them is, let's say the patient is 5 and the front tooth comes out, the bottom front tooth. Their permanent tooth may or may not be coming in fairly soon within the next couple of months. So it wouldn't really be necessary to replant that primary tooth. If they're like 2 and we're worried about the permanent teeth not having enough space, then we may have to consider other options for either, if that tooth had to come out, we would have to consider other options for making space for that patient later, or if it's better to just place that tooth back into a socket and let that space heal before the permanent teeth erupt. So it's really case dependent, but for the most part, mainly I would say that they're taken out for the most part.
And when you secure like a front tooth, you secure it in place, how long does it take to actually have the tooth viable again on its own without the wiring or whatever stabilization you use?
It depends if there's a fracture of the alveolus. So if there's a fracture, usually you splint it for longer. It could be like 3 to 4 weeks. If you don't have a fracture, then you will splint it for around 2. And usually then that will be enough time for the tooth to revitalize. But yeah, it depends on how severe the injury was too.
Interesting.
Yeah.
Okay, we had a question here as well. Can you guys hear us?
Uh-huh.
Yes.
Okay, go ahead, Jean.
I'm wondering, when you talk about the mandible or maxillary fractures, how bad is the pain with that? Because when you're asking them to like open and close your mouth, is it excruciating pain or is it usually pretty tolerable?
It depends. Sometimes it can be completely missed. Like there has been times where the patient's able to open and close and yeah, it hurts, but they don't really notice it. And then it's missed. And then 2 days later they go to the dentist and they're swollen. And then that's when the pain really starts. And then, and then that's when the mandibular fracture is found. It kind of depends on how swollen they are. It depends where the fracture is. But typically I would say a lot of times they're missed a lot of times. It can also be like not a full clean fracture. It could just be part of the mandible that is fractured a little bit. And so there may not be a lot of pain associated with that. But if you push on their bone, it will hurt. They'll notice it.
I had a couple questions, Mika.
Mm-hmm.
On your list, it said for the baby teeth that they would soak them in doxycycline. Is that very common, or is that just dealer's choice? And then the second.
Yeah. Okay. Go on.
And then the second question was, it said, I know we don't want to soak it in water, but they said to rinse it in water was okay if it's dirty.
Yes. So for your first question, that's more of like a dentist directed question or treatment, but they've done studies and shown that if you have an immature tooth, and this is for permanent teeth only, if you have a permanent tooth that's developing, so the root isn't fully formed, a lot of times before they reimplant it, they'll soak it in doxycycline just because it will help revitalize help the cells revitalize. And so far as why that happens, I'm not quite sure, but that's recommended by the American Academy of Endodontics for traumatic injuries of just immature teeth. I think it depends on the clinician. A lot of times they will not even do this. And it depends on how long the injury occurred. So if it's been more than an hour, usually they won't do a doxycycline rinse. For the, what was your second question?
Rinsing off the dirt, and
Yeah.
it's okay, rinse with warm water.
Yeah, you can rinse with warm water. Rinsing it for a minute or like 30 seconds won't desiccate the tooth. The idea is that you don't want to have the solution as water, is because of the osmotic balance. It will really kill the cells if they're soaked in there. But to clean it off, it's fine. I mean, we have resources in the ED that are different than if you were like out in the field. If your kid was at a soccer game, you didn't have normal saline with you. So I would just stick to using normal saline just because it's sterile and cleaner, but you could use water too to rinse it off.
Okay, thank you.
Any other questions?
Yeah, this is Dennis. I was wondering, my son, he had some dental trauma, chipped part of his tooth and it's a little discolored. The dentist had told us that, even years later, an abscess can develop. While still have that primary tooth. Is there anything that we should know or information that we could provide for parents when we're discharging or whatever in terms of like abscesses?
Yeah, so there is always a risk for potential. So in your case, the pulp was exposed. So anytime a pulp is exposed, that means that bacteria can get in there. The cells within that tooth can die. And so when the cells die, that's when usually an abscess will form. This usually takes a while. So it's probably why your dentist said perhaps it can happen. It's not something that you would see within the first couple of days usually, especially after a traumatic injury. But yeah, there's always a possibility that an abscess could form. But yeah, one of the signs would be you would have swelling, you would have pain. You would typically start to have pain that like wakes the child up at night. That is spontaneous. That usually happens very short, like before an abscess forms. Yeah, but usually the first sign would be pain and then swelling afterwards. But in terms of discharge instructions, yeah, you could tell them to look for those signs. And then they do definitely need to follow up with a dentist, because after a traumatic injury, they do serial checkups and they'll check them 1 week, 2 weeks, 1 month, 3 months. They'll check them frequently and they'll be monitoring for all of those things. So I guess the most important would be, yeah, if there's any signs of infection, swelling, fever, pain, and then following up with their dentist would be a big one.